We have spent 4 episodes pulling apart the 2026 ACC/AHA Dyslipidemia guidelines, 123 pages, 11 societies, a lot of COR1 labels. But before we close this series, I want to give you 4 things to walk away with. Then I want to say something about what all of this means for the patient sitting across from you. 1. The rating system is not level of evidence. COR1 paired with a level of evidence of C-expert opinion means a room of experts voted. It does not mean someone ran a trial. Every time you see a strong recommendation, look at that level of evidence behind it. They are not the same thing. 2. The LDL targets are borrowed, not tested. The specific numbers, less than 70 and less than 55, were inferred from the LDL levels that patients happened to reach in drug trials. No trial has ever randomized patients to those targets and measured what happened. The EASY-PAVE trial, published weeks after the guideline, took the first real swing at it in Korea in an open-label study with no mortality signal. The direction is probably right, however, the precision of the specific numbers is not established. 3. Universal LPA screening is currently a COR1 recommendation for a marker you cannot specifically treat. The first outcomes trial has not yet been reported. The only actionable recommendation in the guidelines when you find a patient has an elevated LPA is to optimize cardiovascular risk factors, which you should already be doing. The drug pipeline is primed. Know which part of that story you are in. 4. We replaced the National Risk Calculator with no outcomes evidence to support the switch. Built on data no one can audit, and deprescribed statins in 4.1 million patients currently taking them, while 15.8 million already eligible patients go untreated. The calculator is not the bottleneck. Access and follow-through are. And here's one bonus takeaway. The guideline expands its recommendation for bempedoic acid, inclisiran, and evinacumab. These deserve their own episode, but the short version is this. Bempedoic acid has the strongest non-statin outcomes case. The CLEAR outcomes trial showed a modest absolute risk reduction in statin-intolerant patients. Inclisiran, as we covered in part 2, has 2 phase 3 trials with the primary endpoint that are pure LDL surrogates. Evinacumab carries a COR2B recommendation for a condition, homozygous familial hypercholesterolemia, that affects about 1 in 300,000 people. The pattern across non-statin therapies is consistent. LDL goes down reliably. Patient-oriented outcome data ranges from modest to absent. The guidelines incorporate these drugs anyway. That is a choice, maybe a reasonable one for some patients, but not automatically the right one for yours. So here's what 4 weeks of skepticism is actually about. The guideline cannot see your patient. It sees populations, averages, and clinical trial cohorts that were often the sickest of the sick. Post-ACS, established ASCVD, LDL is still elevated on therapy. Your borderline risk 52-year-old who works 2 jobs, has no insurance, and barely fills prescriptions is not that patient. The medications cannot tell you about their own side effects in this specific person. They cannot tell you whether the cost is manageable, whether adherence is realistic, whether the benefit at the margin justifies the burden. The labs give you numbers. The calculator gives you a percentage. The guideline gives you a recommendation. None of them give you a person. Only you do that. The best version of evidence-based medicine is not a clinician following a flowchart. It is a clinician who understands the evidence well enough to know where it applies and where it doesn't, and who uses that understanding to have a better conversation with the patient in the room. The guideline is a starting point. You and the patient are the endpoint. So, as a cumulative score, the Castelli coefficient for the 2026 ACC/AHA Dyslipidemia guideline is a 6 out of 10. The core statin evidence that underpins this guideline is genuinely strong and some of the best outcomes data in cardiovascular medicine. That earns the floor. What keeps the ceiling down, though, is a rating system that conflates expert opinion with trial evidence, LDL targets inferred from drug trials rather than tested head-to-head, a universal screening for a marker with no approved therapy, a calculator switch with no outcome validation, and a non-statin expansion built largely on surrogate endpoints. A 6 means read it, use it, and know exactly which parts have a foundation and which parts have a vote. Until the next time, this is Dispense is written. Thanks for being here as always.